Addiction is a brain disease.
Addiction is a brain disease.
Addiction is a brain disease. What and where is the evidence? Until recently, there was little scientific evidence to explain why some people lose control over their use of alcohol or drugs. Without much evidence, the public, scientists, and physicians have openly argued that alcohol and drug addiction, which is now called substance use disorders, SUDs, are something other than a disease. As a result, policymakers, image makers, and society fail to understand the nature of SUDs. Thus they often label the person with a SUD as irresponsible. The American Medical Association declared SUDs a disease in 1967, however, acceptance of this view is not universally accepted. Too often addiction is addressed solely by the criminal justice system, and not as a disease that must be addressed by the healthcare system. Not only is there clear scientific evidence that some individuals have a disease, many scientists have affirmed that addiction is a chronic brain disease that can be treated successfully. In fact, it can be as successfully treated as many other chronic diseases like asthma, hypertension, and diabetes. This bold statement is substantiated by neuroscientists, which is the science of the brain and how it works. Addiction as a brain disease is accepted by the Substance Abuse and Mental Health Service Administration, SAMHSA, the National Institute on Drug Abuse, NIDA, and other health organizations. So, what is the science behind this story? To begin to understand the science of SUDs, it is important to understand not all individuals with a SUD suffers from addiction. The American Psychiatric Association, APA, and World Health Organization, WHO, currently provide diagnostic criteria to differentiate between substance users who demonstrate control compared to those who gradually or quickly lose control over their drug use. Those who have the disease can be medically diagnosed by criteria found in the Diagnostic and Statistical Manual 5, DSM-5. So, what we have is two groups. One group can be diagnosed as having no SUDs. The other group is clinically diagnosed as having SUDs based on severity criteria. The term addiction and SUD are interchangeable terminology. Thus, we can talk about what causes SUDs within the brain versus what causes mild, moderate, or severe drug use. SUDs decline through educational approaches, counseling, coercion, incarceration, and/or restriction of drug availability. However, to overcome mild to severe SUDs requires other additional interventions. Genetics and neuroscientists have studied SUDs for several decades. It is now accepted that the primary site of the disease is in the brain's reward system, also known as the mesolimbic dopamine system. It is a closed system in the brain when overstimulated can cause chaos. The dopamine system also affects the orbital frontal cortex, where judgment and executive functioning reside, and control delay and impulse control. Epidemiologic studies indicated that the likelihood of developing SUDs varies widely depending on the drug used. A drug that heightens dopamine stimulation will often hijack the brain and manifest into obsessive and compulsive thinking and behaviors. Although nicotine is a gateway drug, more powerful drugs such as methamphetamine, crack cocaine, heroin, and a host of synthetic opioids, such as morphine, fentanyl, can quickly hijack a person's brain. A SUD does not guarantee addiction because each drug class has a different potentiation. The DSM-5 Severity Index explains psychosocial malfunctioning associated with addiction and specific neurotransmitters that influence our reward pathways. Most people with a SUD get better with treatment. Thus, we can conclude that something obviously changes in the brain, specifically in the deregulated neurotransmitter system. This observation can be seen when people with SUDs begin to improve. Research show that clinical intervention help people get better sooner compared to no intervention. In many cases, individuals with a SUD enjoy sustained recovery for many years. Their treatment may include individual, family, and group counseling, psychiatric medication, addressing medical issues, relapse prevention, and case management. These strategies also help people who experience frequent relapse or experience a fall-off-the-wagon episode. Research show that introduction to 12-step groups enhance and help maintain sobriety. What do professional counseling, medication, and 12-step groups have in common? 1. They help clients make better decisions. 2. They help clients change brain reward malfunction and move toward normalization. 3. They help clients improve their decision-making function. 4. They help establish environmental cues that better recognize cravings and triggers. Some scientists speculate that degeneration of brain regions can never fully be reversed, but only push back toward normalcy. It is much like how taking an antidepressant for depression. It helps a person get through their day while maintaining hope and freedom. 12-step attendance is a daily healing intervention that works. Many people with a SUD report that spirituality helped maintain normalization. Brain imaging clearly showed that counseling methods, such as cognitive behavioral therapy, improve brain function and the quality of life for many. New studies are bridging the gap between psychology and neuroscience. The prognosis for long-term stable recovery varies from person to person. It is based on severity factors, resources, and effort, which builds psychological resilience. Recovery is real and is enjoyed by many with a SUD. I say again, recovery is real.
Hi, this is Fred. If you like this video, make sure that you hit that like button below. Also, share this video with your friends. Leave me a comment in the comments section. Please subscribe to my channel or visit my website at www.StensonEnterprisesinc.com for more information on training and services. Keep it real, and I will see you next time.